Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Today I'm going to cover some heart failure medications. Now, previously in the hypertension section and obviously on previous podcasts, I've covered beta blockers and aldosterone antagonists a little bit. So go ahead and search the archives if you want a little bit deeper dive into those. I'm going to focus on loop diuretics, ARNI, and SGLT2 inhibitors a little bit here. So before I do that, be sure you go check out reallifepharmacology.com. We've got that free 31-page PDF. Absolutely no-brainer for you to have. Great if you're out in practice or you're taking board exams, pharmacology exams. Good little review on some of the most important things about the top 200 drugs. So again, you can do that. Simply an email will get you access at reallifepharmacology.com. All right, so heart failure medications. So let's talk about loop diuretics first. These medications are a mainstay in practice to essentially remove fluid. Mechanistically, loop diuretics block the sodium-potassium chloride transport in the ascending loop of Henle. So being in the loop of Henle in the kidney, that's where the name loop diuretic comes from. And this yields, the most powerful diuretic effect of kind of any other standard medications that we utilize. It's typically considered much more powerful than thiazide diuretics, for example, or potassium-sparing diuretics. So, with that said, this class of medications, furosemide, torsemide, bumetanide, those are the three I see most commonly used. Those medications are going to be the go-to agent if we need to get fluid off of a patient. Okay, so primary use, I'm going to focus mostly on heart failure here and getting that rapid fluid removal. But keep in mind, loops certainly can be used for other purposes. Edema related to renal disease, potentially also related to cirrhosis. So again, we've got other indications potentially for loop diuretics. But yeah, I'm talking mostly about heart failure in this segment. So again, most effective diuretics for fluid removal. IV onset is obviously going to work quicker than oral onset. Oral onset is relatively fast as well, but if this is a situation where it's obviously a patient in acute distress and they're hospitalized or going to a healthcare institution, getting that IV on board more quickly is obviously going to be more beneficial and better for the patient more quickly. So as we escalate dosages, you may see a little bit of a ceiling effect with loop diuretics. This is probably more particularly true in patients with renal disease. We may need to titrate up those dosages, but obviously that needs to be weighed with the risk of causing further insult to the kidney. So that can definitely be a little bit of a balancing act and a challenge there as well. Because when you run fluid off, you're potentially causing dehydration. Okay, that fluid's leaving the body, and if we don't have adequate perfusion, we can cause some damage to the kidney in that way. And so that's why we're typically going to monitor labs very closely. And within those labs are going to be creatinine, for example, which we use to help monitor renal function. All right, so one thing I wanted to mention was oral furosemide does have lower bioavailability compared to IV, so this is something I've certainly been asked about in practice and seen. IV to oral furosemide, in practice, typically it's approximately a 50% bioavailability for the oral agent. So, example here, if you've got 20 milligrams of IV and you want to convert them to oral, typically we're going to start with 40 milligrams of oral furosemide if we want to keep them on the IV dose that they're on. So, again, about double for the oral dosing there. Again, furosemide does have some variable absorption and bioavailability at times, depending upon certain situations. And so when you do any type of conversion, I would say, between medications or dosage forms, and you're basically trying to get the same amount, it's important to watch them clinically. They may need more or less, kind of depending upon how they're responding clinically as well. So very, very important to monitor that. But again, simple way to remember, PO dose is about 2 times the IV dose when we're talking about that furosemide IV to oral conversion. All right, monitoring parameters. I alluded to renal function certainly being important. So serum creatinine, BUN. Also electrolytes. So, with that fluid goes electrolytes such as potassium probably being the number one concern, but also magnesium and sodium can be depleted there as well. And then in addition to renal function, obviously going to monitor volume status as well. So weights are frequently monitored in heart failure as well as urine output. All right, adverse effect profile. One of my major concerns is hypokalemia, so dropping potassium levels. And if we drop them too far, obviously that can put us at risk for EKG changes and arrhythmias and things of that nature. Ototoxicity or ear toxicity is associated with higher dosages, prolonged use of furosemide at those higher dosages. So that is something to pay attention to there. And then, of course, when we're kicking out fluid, so dehydration and causing acute renal failure that way is a potential concern, as well as less fluid in those vessels. So that can drop blood pressure too far and potentially cause hypotension and dizziness and things of that nature. Now, from an ambulatory care standpoint, frequent urination is a huge problem that I have dealt with in the geriatric patient population. If the diuretic doesn't seem to be working in an outpatient setting, definitely ask about adherence, okay? The frequent urination can be really, really bothersome for patients, and oftentimes, particularly if they're active and they're social and they lead an active lifestyle, going to the bathroom every 30 minutes, hour is very annoying for a lot of those patients. And so oftentimes you may see them skip doses and things of that nature. So really got to pay attention to that frequent urination, see how troublesome it is. And, this is why we generally dose loop diuretics on an outpatient basis earlier in the day as well, so patients aren't getting up at night constantly to go to the bathroom and obviously interrupting their sleep and putting them more at risk for, falls and other negative consequences. All right, let's move on to ARNI. So this is an angiotensin receptor neprilysin inhibitor. And this combination is sacubitril valsartan. Valsartan is an ARB. I've covered that class previously, but I did want to hit on this briefly here. So again, that ARB is valsartan, and that blocks the renin-angiotensin-aldosterone system. And then neprilysin inhibitor, sacubitril, this increases natriuretic peptides, which can ultimately help with diuresis as well as potentially vasodilation. So this really is the preferred go-to agent kind of for chronic management now over just using an ACE inhibitor or just using an ARB by itself. Okay, so the guidelines do lend towards using this medication. Again, been shown to reduce mortality, reduce risk of hospitalizations with heart failure with reduced ejection fraction patients. All right, very, very important practice Pearl and test prep Pearl. You must stop the ACE inhibitor for 36 hours before starting this medication. The primary reason for this is the risk for angioedema. So that's that swelling of the lips, face, and ultimately the airway can swell up if severe and cause some respiratory distress there. Monitoring parameters, pretty straightforward. Blood pressure, potassium levels, renal function. Those are going to be the big ones there. Adverse effect profile, very similar to ACE inhibitors and ARBs. Hypotension, elevated potassium levels, and that risk for angioedema. All right. moving on, let's wrap up with SGLT2 inhibitors. So these have been a class that has grown in popularity due to supporting clinical evidence in the use of heart failure. Ultimately, these block glucose reabsorption in the proximal tubule, glucose and sodium excretion, and it also helps with osmotic diuresis. And this has been shown to help with cardiovascular benefits and obviously treating heart failure here, as well as potential renal benefits with these medications as well. So examples, empagliflozin, dapagliflozin. And again, primary use is heart failure or diabetes, type 2 diabetes. Those are the most common uses. It can be used in preserved ejection fraction heart failure as well as heart failure with reduced ejection fraction. So that's kind of a unique thing there. There's evidence to support both. Ultimately can help reduce those hospitalizations, can help that renal function, and can maybe have a little bit of a mild diuretic type effect, which can potentially complement what we're trying to do sometimes with loop diuretics. So those benefits of the SGLT2 inhibitors are without the beneficial effects potentially on diabetes. So if you've got a patient with reduced ejection fraction and diabetes, it's probably a no-brainer, to want to utilize this medication class. Obviously barring some contraindication or intolerance. It's definitely going to be high on the list as far as drugs that you would pick if they have diabetes with heart failure, but also want to point out the benefits in heart failure included patients without diabetes. So definitely very, very important to remember that. The SGLT2s are considered some of the foundational therapies now when we're managing heart failure, along with the ARNI, beta blockers, and potentially the aldosterone antagonists as well. All right, what are we going to monitor? What do I pay attention to? Renal function. So you may see a small initial dip in GFR. Again, kind of can have a mild diuretic type effect, but ultimately can help in preserving renal function too. So that's a nice thing. Volume status, signs of infection. So particularly genital mycotic infections, urinary tract infections. When we cause sugar to go out through the urine, which is how it works in diabetes, that increase in sugar in the urine can potentially promote the growth and development of bacteria and fungi. So really important to pay attention to those genital urinary infections. In my work as a consultant pharmacist, it's definitely something I ask about if I see a patient has frequent genital urinary infections. I see a couple orders for treatments of these that should be a little bit of a red flag in your mind, like, okay, what's going on? Are they on an SGLT2 inhibitor, that may be causing or contributing to this? Volume status, I do, pay attention a little bit to that, and you want to pay attention to blood pressure as well, particularly when initiating these medications or obviously changing blood pressure medications as well. There is a rare association with euglycemic diabetic ketoacidosis. So essentially, the patient can have kind of all the classic symptoms of diabetic ketoacidosis, but their blood sugar really isn't, crazy high. Okay, so their blood sugar is, maybe around 200, for example, give or take a little bit there. So again, blood sugar is not crazy high, but they can still kind of have this diabetic ketoacidosis syndrome, even though those blood sugars are relatively normal and not crazy high. So important to think about that if you work in a hospital setting and you see a presentation of acidosis and you're thinking diabetic ketoacidosis. but you're like, well, blood sugar's not really that high, it could be this situation, and they could be taking an SGLT2 inhibitor. All right, well, that's going to wrap up the podcast for today. Hopefully you picked up some practice pearls as well as some test prep things. Do me a huge favor, go to meded101.com/store. Support the sponsor there. We've got tons of study materials for pharmacists, pharmacy students. We've got books on Amazon. We've helped thousands of pharmacists and pharmacy students pass their board exam, and those materials can absolutely help you too. So again, go check that out. If you enjoy this podcast, support the meded101.com/store page. If you're a pharmacy technician, nurse, med student, we've got stuff for you too. We've got books on Amazon, educational case studies, lots of different things that you can learn from as far as pharmacology and medication safety. So again, all those links you can find at meded101.com/store. Don't forget to go to reallifepharmacology.com. Go ahead, search the archives there. Hit the podcast button, search the archives if you're looking for a specific drug or class. I've covered a lot of podcasts over the years, so there's probably something for everybody if you need something there. So go check that out while you're there. Also get that free 31-page PDF on the top 200 drugs. Great, no-brainer to have that. Simply an email will get you access to that. Comments, suggestions, reach out to me, mededucation101@gmail.com. You can also track me down on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. If you love this podcast, do me a huge favor, leave a rating review on iTunes or whatever platform you're listening on. And I thank you so much for listening. Take care. Have a great rest of your day.